few minutes late, so we'll just have to take time to probably discuss one or two cases out of the three we have selected. Is my pen drive coming up here? So I'd like to call upon Dr. Martin Sarangi, Dr. Jihar Akos, Kailash Patel. I guess Kailash has already left. Nishikant and Dr. Nishikant and Dr. K.S. Anand. So if you all gentlemen can come up and share experience with this audience. I have just one or two cases for you and see how you would have dealt it. Right, thank you. Right, we'll wait for the slides to come up. Okay, so thank you, gentlemen. We'll have a pointer here. Yeah, good. Right, this works. If you guys. Okay, so a 65-year-old lady, pain left knee, unable to take weight on the left lower limb for last 6 months. So technically, for last 6 months, she has been immobile, hypertensive, rheumatoid, query, because she is, and the scenario in here is completely different. People are seen by so many doctors hit and trial medicine, so we don't know. Patient is on DMARDs, but you'd never know. She was actually a rheumatoid patient, but she is on DMARDs. Okay, and BMI. So I've just not mentioned anything. She's huge, so I don't know it was 35 or more. Okay, so she was huge, short stature, 5'4" and weight around 110 kgs. So. Sorry,
but you say BMI huge, 35 or 55?
More than 35.
Okay. So
more than 35. Yeah.
Rest of Scotland, that's
normal.
Because
she couldn't stand, so we couldn't weight her. But when looking at her general picture, it looks like she's
about 50. It's called super obese.
Super obese. Okay. Right. So it's not going forward. Guys, Hariji, it's okay, thank you. So that's her X-ray. So we managed to get her stand on one leg, on both the legs basically, and we managed to get her knees X-ray. So this is what, if you can see, I think this screen is a bit more clear than what we are getting for the audience. She's like this, and she says that for last 4 to 5 months since she has not been weight bearing. Because it started suddenly. She was able to weight bear, but then suddenly she's now for last 6 months not unable to weight bear. So we thought, okay, something wrong is going on. And do you think that you can make a decision on this? You want something else? Because we did something else, so that's what I'm asking. You want something else?
Did you get a scanogram?
We couldn't get a scanogram because we don't have that kind of. We do get scanogram for all the patients, but it's 3 X-rays taking at a time. One go, so we didn't have time. So for 1 AP, we could make her stand, but for 3 APs, 1, 2, and 3, we couldn't make her stand. So we couldn't get her scanogram. We did something else, so we couldn't get that scanogram done. Though we do get scanogram for all the patients, but. Sorry? Did you do a long leg film? Yeah, that's what he was asking. Like, we couldn't get a long leg film. Yeah, for this particular lady.
A skyline view from the patella?
No, I think we had it, but I haven't put it. We got the CT done to see exactly what is going on, because we wanted. We have never seen defect like this, any crumble bone. So we got the CT. Okay, I'll play out the CT one by one. So that's one of the sections. That's one. So that's the sagittal, that's the coronal for you.
So as I was suggesting that CT should have been done, which actually has been done. So that shows that there are fractures on the middle side, or the defects.
Yes.
The bone is not in continuum.
You can see that if you want that axial to be played again, I'll just do that. So the one on your right.
Very impressive.
Yeah, so it's kind of an uncontained, whatever is happening is really uncontained, not entirely confined to one condyle, it's going across. So how do you approach this patient? What are you looking for when you're dealing with such patients? Yeah, we did. So there was nothing to suggest, all the markers, everything was fine, except raised a bit CRP and ESR, which these patients will always have because of the inflammation and the process that is going on, pain and things like that. But it was nothing alarming because we evaluated this patient over a period of 6 weeks and we did all those things twice just to be very sure. We couldn't find any signs of inflammation.
Any neurological disease?
No,
behind?
yes, no. Nice, good question. Actually, nothing. Nothing. Everything was fine. Power 5/5, except a bit weakness around knee because she was unable to do. But the distally it was absolutely fine.
And for how long it was painful?
See, it was painful for last 3-4 years, but last 6 months she has not been able to take any weight on it.
Deteriorated.
Yeah.
Have you excluded the stress fracture over the tibia?
Sorry.
Stress fracture?
Yeah, over the tibia, yes, we included everything. We scanned everything because we wanted, if you are using any implant, we need to, how down we need to go to expand it. We did that, yes. We didn't get the bone scan, but while scanning the CT, we just get a scout film and saw that she's fine.
So I think the main issue is here is the tibial defect,
Yes.
which involving more than half of the unicondylar involvement is there. And the depth is more than 10 mm, I think.
Yes, it's more than
So, and how is the laxity?
laxity, she was not letting us examine before we took her in the theatre, so it was very difficult to assess. She was so painful. If you start giving a valgus stress, she was very painful, whereas of course she was completely collapsed on medial side. So we couldn't really assess, so we had to be prepared mentally for anything worse. So yes, when we couldn't assess that properly.
Any assessment towards osteoporosis? General osteoporosis?
Generally, she was fine, actually. Generally, she was fine. Her density of the wrist and spine wound, because we do have to do a spines routinely. For anesthetist sometimes wants it, we are getting it routinely done. She was absolutely okay. Yeah. You can see these X-rays. So she's a bit osteoporotic, but that's what normally, a bit more than the normal osteoporosis, but then probably the 65, I'll say she was okay for
maybe because of non-weight bearing.
Non-weight bearing for 6 months, and other side was also okay. So there's nothing to suggest that anything hidden sinister is going on. So how would you approach, like what would be your implant choice? What implant you want to be present in your theatre when you're approaching such patients?
Constrained.
Okay, that's one.
I was just talking to Nishikant here before you asked me the same question. So I said that I'll use a constrained knee, semi-constrained knee. Yeah. And he said that probably he'll say what he has to say. Right. Yeah. So I'll use a semi-constrained knee with a rod in the tibia.
Right. Okay.
So I think the major issue here is the bone defect here. So I will have a rod for both sides, the tibia and the femur, ready in my operating theatre.
Right.
I will have augments ready as well. Few of the screws to put in the defects, and the bone we have already. So we have the metal augments ready, the rod and the fissure screws ready.
Screws definitely ready. Okay.
So basically the femoral side looks pretty much like a primary knee side on the femur. It's got a huge big medial tibia defect, and you definitely need a stem, and you definitely need to build up the medial side. And you can argue whether you want a cemented stem or a press fit longer stem, but it definitely needs to be stemmed.
Okay.
And I would argue that if you need a stem, you probably need some constraint on the femur, although it looks relatively spared. So I would go for a semi-constrained as well.
Right. Okay. So we had all those things in mind, and unfortunately, that you want to make some comment? Yeah.
Just wanted to say that you have to reconstruct the tibia side, and you can use bone graft. So you have to consider having a bone bank or bone grafting possibilities, or you can also use some trabecular metal or whatever porous metal cones.
Yeah.
Maybe asymmetric. So it's also in terms of implant selection, you need a huge variety of implants, and maybe you have to order some special implants from your company, so from your supplier, because it's mostly not off the shelf.
Yes.
So this surgery has to be prepared quite well.
Sir, I have a question here. I will agree to some of the part which sir has said. Can we just fix the fracture and like put a bone graft, fix the fracture, make it like a primary, and then do the primary kind of thing?
It's not a fracture. It's not a fracture.
It's crumbled actually.
Yeah, it's crumbled.
It's
but
crumbled.
We are much worried about the peripheral part, the posteromedial and the medial part which has broken down.
I'll show you the CT again. If you see the axial cuts, you'll find that it's actually crumbled. Just keep an eye on your axial cuts. So you hardly see anything to be salvaged here. Anything to be salvaged. I'll play that again for you. There's hardly anything you could salvage here. There is anything left to be fixed. I doubt there is anything left to be fixed. So if I freeze the frame here, there is hardly anything you could actually connect together. So that's where we thought doing anything other than a replacement would not work. And that's a good idea. I mean, that's another idea. It's good that we all are engaging. So the masters are here. I have a case. I don't know whether we have done right or wrong. So just ask them. Don't look at me.
Just about the fracture, it's not fracture. The whole thing was crumbled. Since I know what was inside, I'm not revealing that now. But if you see, it's all small pieces, and nothing is continuous. So if it had been a fracture, then
then of course we could have a choice of fixing it and going ahead.
This is more a bone destruction than a fracture.
More of a bone destruction.
It's a defect situation. So it cannot be healed like the fracture treatment.
Can we consider reducing it to somehow, and we can give the plaster for some time to heal?
No, but
and
there is
again
no
we can
fracture.
consider, because
There
you
is-
have told me already that there are CRP and ESR is also raised, and the joint is hot.
Can I ask
wait
you?
the joint to cool down, and then CRP and ESR to come normal, and at the same time we can give the plaster, and so that he can heal whatever in position, whatever the deformity, and then we can correct it with both extension rod on both the sides.
No, so
Can I ask you if you do that? Sorry. Can I ask if you try to reduce it and put it in a plaster, what do you expect?
Because the ESR and CRP is also raised, he told.
No, it's
But
very
this
slightly.
is a
It's
rheumatoid
very
The patient
slightly.
is also on DMR.
Very slightly raised. So nothing. And over the period of 3 months, 6 weeks, or 8 weeks, where we went on evaluating, arranging for implants, we couldn't find any change in those values.
But
And
again,
nothing to suggest.
but
it's
again there is some question. If the CRP and ESR is raised, it can also suggest some infection also.
That's what I'm telling you. That
So why
it's,
not we
it's
should
not.
wait to
It's
see the
not
CRP
that
and ESR
raised.
to come down.
So maybe that's not a bad idea if you have a bone destruction.
Only raised
Rheumatoid
CRP should not be
arthritis.
criteria for infection in the knees. I think CRP is also raised in cases of inflammation as well.
Yes.
So CRP is not the sole criteria, I think.
And
I was-
That's why we are asking ki, why shouldn't it come down, and then we can proceed, and at the same time we should give the
He
plaster.
must have waited for that. He must have waited for that.
I haven't revealed what I have done. Sorry, I haven't revealed what I have done.
Yeah,
so you have to
just
wait.
discuss
Can I say, if this is the case, I think it probably wouldn't be unreasonable to do an aspiration before, just to do a proper workup for infection.
So
Because-
we went ahead with an aspiration. We sent it in the lab, and nothing came out. We evaluated her urine, teeth, and everything, every possible cavities of the body which could have been infected. Okay, so
Sir, there is a request. Can you play the coronal sections once again?
okay, you want to play the coronal once again? Okay.
Everyone, please pay attention.
And you won't tell me when to stop. Okay, sir, I'll just.
Stop, sir. Stop.
Oh, sorry. That's the mouse. Okay. Again, I'll go. Oops. Sorry, it's playing some tricks here. Right, so the implant wise, we had everything in mind, and We thought of, we aspirated, we sent the aspirate, urine culture, everything was negative. Absolutely, there was nothing, no sign, nothing was suggestive of infection. And unfortunately, this patient came to us at a time when the government capped the price of the implant. And suddenly, the revision implants were absolutely hard to get. So we were unable to get the revision implants, and there was a time when everybody will agree that aspirate. So if the cultures are negative, you can go ahead as planned.
Aspirating, can we go for WBC scan?
Sorry?
WBC scan.
WBC?
Scan.
WBC scan. No, we don't do WBC scan.
Okay.
We don't do WBC scan.
So why to go for invasion in the joint where we are going to replace and we are again going, why to invade the joint?
Why did I aspirate?
No, yeah, definitely. Should we aspirate? Or
No,
in
why
place
not?
of that, any other option we should consider like WBC scan, Indium scan?
Yeah, we don't have WBC scan.
Yeah.
We don't have WBC scan. So,
If you compare the sensitivity and specificity of for aspiration versus the bone scan, the aspiration is always good, better.
I mean, I'll anytime rely upon a direct evidence rather than an indirect evidence. Let's face that fact. There are times when the bone scan in a hemiarthroplasty reveals there is always a confusion between loosening and infection. So I'll always say my patient, I'll go for a 2-stage with the slightest of hint if I get infection. So there is no doubt a direct evidence is always better than an indirect one. And direct evidence is what? You grow a bacteria in the best possible lab that you have. That's it. So you aspirate, send it for culture. If you're growing something, that's fine. If you're not growing anything, you are absolutely justified.
Again, after joint tapping, how many days we should wait or we should go immediately?
Okay, so how many days we should wait? See, the normally extended culture will take 5 to 7 days because normally if nothing grows for 3 days, I ask my microbiologist to extend it for 5 days. Definitely I'll wait for 15 days. I'll not rush him. There is no rush. In this surgery, there is no rush. Patient has not been weight bearing for 6 months. There is no harm waiting for 1 month even.
Exactly.
Okay?
So
yeah,
that's why I'm asking, if you have to wait for 15 days, can't we wait for 1.5 months so that bone should heal sometime?
Bone should heal. Do you think this will heal? See, there has to be a bone to heal. Bone has to heal on bone. Bone can only heal on bone. There has to be a bone on bone healing. Bone cannot heal with fibrous tissue, or bone cannot heal with soft tissue. So there is no bone to heal with each other. Okay.
And one most important thing is do the aspiration in a sterile environment. Don't do it. Yeah, that's the most important
It's
thing.
done in theater, so it's never done in an outpatient scenario. Never ever.
And
Never ever
the
done
advantage of aspiration is that you have the germ and the susceptibility,
Everything.
and you know what you are dealing with, and you can make a plan for antibiotic treatment. With the WBC scan, you have one more step, and then you have to go for aspiration.
Again, you have to go back. Again, you have to come back.
So I prefer aspiration as well.
Yeah. So, and nothing came out. So, and once the implants were arranged, and that was roughly, again it took 6 weeks for us to arrange the implant that time. So roughly more than 6 weeks had passed. And so this is what we found. Okay, I think that screen is much more cleared up. It's a bit better. So everything was crumbled up, as you can see on the CT. So that's the one image from the top. On the left side is femur, on the right side is the tibia as we saw it after opening. So everything was crumbled up. It was more on the medial side, extending onto the lateral side, and absolutely no sign of infection. No sign of infection. So what we made out after the surgery is that she was having arthritis, and the bone gave way because of her own weight. It just crumbled. She crumbled under her own weight actually. So that was probably, it was weak because of the DMARDs and steroids that she was taking, and she just crumbled up. So this is what we got, and this is what we did. So we used the metaphyseal sleeve, MBT tray, and extension rod, because the defect was a bit too much for the augment, and honestly speaking, we didn't have augment. We didn't order for an augment. We were pre-set up with a mind that we'll use a metaphyseal sleeve. Anything, if we at all are going to do a one-stage surgery. Femur was fine, ligament balancing was excellent. So we went ahead. We didn't use any rods or anything. So we went, and we have seen this patient at 3 months and 6 months follow-up. She's doing fine. She's walking now.
Are you happy with the joint line here?
A bit not really happy because we realized it a bit late when we started flexing her. So probably we could have used a different poly because the poly used was a standard poly. We could have used a different poly. Eagle's eye, spotted it on.
Have you ever felt the need to put the rod over the femoral side as well?
There was nothing.
Because the patient has stumbled herself. So she must be osteoporotic.
But then when while cutting the distal femur and taking all the chamfer cuts, the femur bone stock was looking nice. But yes, we could have done that.
The main major drawback in these cases are the main osteoporotic area is the metaphysis.
Is the metaphysis. Yes, we could have done that. Good point actually. We should not take any chance since patient has invested so much. It only had few more thousand, and we could have been sleeping nicely after this case. Okay. Anything you want to comment, add on? See, we are yet to see the bone growing up. We are in 6 months. I was told, and I have seen the pictures that the bone grows up along the metaphyseal sleeve. But to be honest, 6 months I haven't seen this lady bone growing up. So I'm hoping. But since she is fine. So, and no loosening, nothing. But the bone hasn't grown up. Yes. Probably we haven't done anything extraordinary medically to her.
It appears to be insufficiency fracture osteoporotic.
No, but then there was nothing to suggest that it was an insufficiency fracture. Yeah, the fracture suggested, but the rest of the bone. But then teriparatide. What's the evidence that the teriparatide is working?
There is sufficient evidence, definitely, to build up bone. There are a lot of studies. We've been denosumab.
It's a catch-22. It's catch-22.
Nowadays, 6 monthly denosumab is available in India.
but that's a bit. We started her on vitamin D and calcium and
I think
bisphosphonate. But
one thing, if you compare this PTH versus denosumab, I think PTH is more relevant here compared to denosumab because denosumab acts over the osteoclast, not over the osteoblast. So it decreases the osteoplastic activity. We need to increase the osteoblastic activity here, so PTH is more relevant here, I think so.
I think so.
We started her on vitamin D, calcium and bisphosphonate probably, and she looks fine actually. Probably
Full weight bearing?
full weight bearing, yes, absolutely.
So how was your MCL in these cases? It was
just a standard one, yes, just a standard. Do we have time to take one more case just to... Yes. Okay, so one more case. 70-year male, pain bilateral knee, hypertensive, could barely walk, more than 1 year now. Sorry. ये screen पे छोटा हो गया. The screen on screen. So yes, okay. Now we are live. Okay, so again, standard, probably standard Indian knees that we see more or less. And nothing, no caveat in this. The point I want to ask you is that I'll go further, and this is what we get when we took the cuts, okay? And this is the defect that you're seeing on the medial side. So how you approach your defect, it's not about what I have done, it's about how each one of you individually, if you can take this case one by one, if you, after taking the decent amount of cut, how do you approach? I know you have everything, most of you will have everything armamentarium. But those we don't have everything right on the shelf. Still, of course, planning is very, very important. But what are the things you will plan? How will you start thinking about taking down the defect, and how do you approach? So
I can we go over back the X-rays? We are dealing with knees we are very badly deformed. So I'll like to go with the whole armamentarium. Everything should be there. So if metaphyseal defects are there, so I should have those implants will help me in augmenting. I should also have access to, if possible, bone bank and graft. So now you go one forward. I like to graft it. Grafting.
Okay. So you would like to graft, Nishikant?
So I always classify my bone defects. So if the defect is less than 5 millimeter and the involvement is less than 50% of the hemicondyle, most of the cases downsizing the tibia and translating the tibial component laterally works.
Good.
So the filling the defect with the cement or the reinforced with two screws. So that works in almost 80% of the cases.
80%, yes.
So and whenever I do that, I always put rod in it.
Okay.
To just protect my
to be on the safer side
and increase the fascial growth.
Okay.
So
augment?
If the defect is higher, involvement is more than 10 millimeter, involvement is more than 50% of the hemicondyle, then most of the cases I try to replace the defect with the bone.
With the bone.
Okay. Because putting in augment is not easy.
Not
you
easy.
need to resect the normal bone. It's always difficult. The cost is a factor in our country.
Of course. Yes.
And resecting a bone, you are resecting the normal bone.
So you're sitting there to give us a different perspective than these two gentlemen. So two of you are sitting there to give your perspective for yes, Dr. Sarungi and
I actually would agree that on this occasion a bone graft with support would be better than a graft.
So you suggest bone graft would be for this?
Yes.
So do you have any cutoff landmark in your mind that if it is more than 10 or if it's more than 15 or less than 10 you'd screw? Do you screw and augment, screw and cement, augment? Do you do that?
I think it depends on the type of the defect. If it's this kind of defect and it's about 10 mil or more, this is actually begging for a bone graft. You can put a bone graft, you can screw it, and you have basically a good bony surface.
Yep.
If you have a defect which is similar to the previous case, that's a total different ballgame, because that's a destructive bone. For those kind of defects, I would use
this is
either
what
an
probably
augment.
most of us get more often than not.
This one ideally I would bone graft it.
You'll go for a bone graft.
Yes.
Do you ever? What's the role of screws and cement in your surgery? Do you ever use it?
No.
No. So if you have a defect which you think cannot be managed with downsizing or with the cement, you go with the bone graft.
Yes, for this kind of defect.
Yeah,
yes.
for this kind of defect. Okay, Dr. Kos.
But you can also consider cement to fill to the defect up to 5 millimeters.
Yeah. Okay.
And between 5 and 25 millimeters, you can use bone grafts.
Okay.
If you have the step cut technique, you maybe don't need screws, maybe 2 pins, or not even without pins can be working.
Okay.
If you have a oblique surface, then you have to use screws, otherwise your graft will slip out from the defect.
Okay.
And above 25 millimeters, I always go for metal augments
Metal.
in combination with long stems.
Steps. Okay. So we have three very valid points. I think Johannes, you want to add something. Dr. Patnaik, you want to add something. I think you agree. All the experts sitting down there will agree. What these gentlemen have just told us is that there's nothing like augmenting it with bone. So that's Mr. Sarungi is saying, nothing like augmenting it with bone. You have to see how bad or how deep the defect is, and then if you're not able to, if it's more than 2 centimeter, 2.5 centimeter, probably go with a metal augment. And using a metal augment, always use a rod. And do you use a rod when you're managing your defect with bone? Do you use rod on the tibial side?
You have to bypass the bone graft. So your implant should always be longer than the bone defect and the augmentation with bone grafts. So you always bypass. You can bypass by 2 centimeters.
Right.
You can bypass by 12 centimeters.
Yes, or 15.
It depends
Yeah.
on the bone quality.
Okay.
Depends on the size of the defect. It depends on the age of the patient. It depends on the activity of the patient. So
Excellent.
it's always an individual decision.
So Mr. Sarungi, yes,
If I would use a 5 millimeter augment, for example, when you convert a unit to a total, I wouldn't use a stem. But if you use a 10 mil augment, then I would definitely.
And if you're using a bone graft for this defect, would you use a rod?
I would do the same. If you have to go deeper where the bone graft.
So you have
is.
to use a. I mean, if the keel is not that big of your implant, probably you'll use a rod.
My threshold is quite low in terms of using stems, because in a revision from uni to total knee, I always use a stem, a stubby stem, a small stem.
Small stem.
In order to have more anchorage and more stability, and not to have any failure, because if you use a
you want to
3 centimeter stubby stem, it's
you want to sleep
beneficial for the
peacefully
patient.
in night
And
after the surgery.
if you guys have been to the endoclinic and you have seen in the endoclinic we had a very low threshold also for hinges.
Okay.
No? So in this case we would have resected.
Yeah, I was told that endoclinic has a low
resected the
threshold
whole
of
stuff,
hinges,
put in a tantalum cone, and put in a rotating hinge.
Yeah.
But
Okay.
of course, it depends on the age of the patient. A young patient, I would not use a hinge.
Nishikant.
I think you will never repent putting a stem.
Yeah, so you said
But
that
you
you
can
made it
always
very
recommend not putting a stem.
Yes. So I think as a rule of thumb, yes. Doctor.
Just to ask a question here, the stem, how long would you prefer? Because they come in different sizes. So
That's what we said. Just bypass
bypass the metaphyseal.
The shortest possible stem.
Your stem should have anchorage in the metaphysis.
Okay. And do you want to cement that when you are cementing, or you?
I always cement.
Or you want to have a wider stem? Means it has a fit there. Means
If it's a straight stem, I use cement. If it's an offset stem, I don't use cement. Then it's a hybrid fixation, because offset stems shouldn't be cemented.
Super cemented. Okay, thank you. So, okay, fantastic. All nice opinion. So we tried to augment it with screws, and this is what we got. Okay, so probably yes, we should have we should be using bone graft more often than not, because we are probably not using bone graft. I'm sure that we'll be using more and more of bone grafts. We are using, because this saves time. Bone graft takes a bit of time. Okay, thank you. So I'll bypass this one, and this is the case I want to discuss. Nothing has been done. So this was presented to me yesterday only. Okay, so I haven't seen the patient. Just an X-ray. Opinion on the X-ray. I have asked the patient to be coming in Monday or Tuesday probably. So 62 years. Have not been walking since last 1 year. And this is for last 1 year, and this is the condition. So you can see it. Okay. Probably these guys, that projection is not that great. So giving everything is okay, everything is fine. There are no caveats and no comorbidity. If this patient comes, of course, patient will be hypertensive, diabetes. That's the common scenario. How would you approach implant-wise? Will you tackle the problem separately, the knee and the proximal tibia separately? Would you like to go in one go? How would you decide? So 2 basic questions.
So,
Okay.
If the patient is fit and there's no much comorbidities and is not very obese, I would try to do it in one step.
In one step, all right? Okay.
Do the osteotomy, bypass it, and then probably on the femoral side you can almost put like a normal femur.
Okay. So, are you worried about reducing the length when we are taking that sclerotic portion out? You worried about anything? On the joint line, nothing will happen, because patella tibial tuberosity is way up, so you're not worried. So
I think the tibial tuberosity
is way up. It's way up in the proximal fragment. But you're happy to go in one go.
Yes.
What are the scenarios when you will not go in one go and probably address the fracture first? Is there anything in particular in your mind when you decide not to go for one go surgery? Is there anything that will keep you slightly worried?
First of all, you have to rule out if it's a septic non-union,
Okay.
if it's some septic history, some germs. So in this case,
Probably if it is not.
labeled bone scan could be a good idea in this
Okay.
case, in this particular case,
Okay.
because you want to see why there is a non-union. What was the reason for the non-union? One of the reasons could be an infection,
Okay.
and maybe MRI is also helpful in this case to rule it out. If I have no suspicion of infection or no history of infection, I would go for a one-stage service with tibia reconstruction and a reaming and uncemented stem,
Right.
and bypassing this non-union quite well, maybe 6 centimeters, twice as the distance, the diameter of the tibia,
bone. Okay.
and then I would go for a one-stage procedure. And in the most cases, you don't need a plate, but you can also consider to add a plate.
So very valid point. You need to
from the medial side, anteromedial side.
Okay.
Well, what I feel in our present scenario, in our setup, in our state, I think I'll first would like to ensure that the fracture heals. So for me, with my very limited experience, probably I'll first do all I can to make sure that the bone unites. So I will not go for one-stage procedure. Maybe I'll first
Fair
like to.
enough. So but the implant choice for getting the bone to heal would be
will be a plate.
Because
dual
really would
plating
be
from both
difficult.
sides.
Okay,
yes.
dual plating. Okay.
Yep.
And lot of bone graft probably.
Yep, yes,
lot of
yes,
bone graft.
certainly.
Okay. Nishikant, yes.
So I will always do it in one stage. Most important thing in these cases is whenever you are taking a tibial cut, your bone gets more, the tibia gets more posterior slope.
Yes.
So how do you manage that? Managing that is a difficult task.
Okay.
So there are two issues with that. You first need to plate it with a propositional friction with a unicortical screws, then take your cut. Or you can use the intermedullary rod.
Yeah, the intermedullary jig.
These are the two tricks involved in these cases. So I will always do it with a single stage. Put a plate first, take my tibble cut, then put a long rod in it.
Or probably prepare your femur first. Then go for tibia. Prepare your femur first.
Even then
you need to have intermedullary.
It's non-union.
It's non-union.
It's non-union.
Yeah.
So your tibia gets more.
So you have a longer incision because you want to freshen the fracture site. Do you like to graft or do anything to it?
No.
You can use the distal femur cuts and just crumble it up and put it around if you have a bone mill, if you're doing a hip surgery. No?
As your mechanical axis gets aligned, it will heal automatically.
It should heal, yes. Okay. And do you do intra-op C-arm? For these cases, use intra-op C-arm. So you have to prepare with the C-arm as well.
To be honest, we don't use C-arm for this case, but of course it's of an advantage. But from my point of view, it's more important to debride the non-union, to remove the scar tissue, to freshen up the surface. Also from intramedullary reaming, you will have a lot of bone marrow. And now we have also fancy stuff like enriched bone marrow or some other providing by the industry.
Right.
Platelet-rich plasma whatsoever.
Probably which we won't be able to get our hands on. So
of course you can use that, but it's also without this equipment. If you do a reaming and medullary tissue can be freshened up, then you can have a good alignment and a good chance for
healing
the fixation. And I wouldn't go for double plating. I would go for intermedullary nailing with a prosthesis and an additional plate.
Right. Okay.
To understand the cause of fracture, the cause of fracture is not the trauma.
No, it's
the varus with osteopenia.
With osteopenia, stress. Probably patient was walking, developed unicortical fracture, continued walking. 1 year had fractured completely, and she's unable to walk, and she's just lying down, neglect. That's the scenario.
Even if you plate it, it won't unite.
Probably
because the main contributing factor is in the knee.
Is the knee. Okay, so maybe next year, once I'm done with this patient, I'll present it. Yes, Dr.
Maybe I'd like to differ with my able friend Nishikant here on the point that it will not unite. I think, just for the fun of it, can we have an audience from the house, a poll from the house as to one stage or two stage? Can we?
Yes, please. Yes, why not? Yeah, it's how many of us would like, or would you approach this patient in two stage? Just a show of hand, how many would like to deal fracture separately, let the fracture heal, and then go for definitive surgery or some other surgery for the knee replacement? Okay, Kushag, 1, 2, 3, 4. Okay, so, and how many would go for a one-stage surgery? Okay, so quite a fair amount. But there are people who would go for two-stage surgery, because there is always a theory that you let the bone heal, probably patient won't ask anything else. Patient won't ask anything else. Maybe. Who knows?
And proximal femoral osteotomy, fibular osteotomy is already there.
Fibular osteotomy is already being done by the nature. Yes. Okay. Dr. Patnaik, anything you want to add on? We are done. We are done. Yes. I haven't dealt with this patient. Yes. Limb length I asked, but then you can build up, and then later on you can actually
that
give.
That is the only concern, because some amount of sclerotic bone has to go.
Sclerosis is there, so then naturally that needs to be cleaned, and there will be a gap. You can put some graft over there.
Maybe you can do a step cut, something like that. Step cut. Or
next knee is also bad, so we can compensate with the other knee as well.
Okay, so I think I have been given a warning thrice actually in my lecture and here in this session, so I won't extend. Thank you very much, gentlemen. You have been a good sport. Thank you, Mr. Sarangi.
I must commend you on the way you have conducted. You have conducted so nicely, so thank you so much for asking such valid questions.
Excellent cases.
Thank you. I hope the audience would take some take-home message from these cases that we discussed and the experience shared by the experts here. Thank you very much, gentlemen. Have a lovely evening. We'll see you in the dinner. Thank you, Nishi.